Welcome to Connecticut eHealth podcast, educating, conversing, and connecting for better health. The Connecticut eHealth podcast is a space where we get together with local and national experts, key stakeholders, and other individuals in the space of eHealth to discuss health information in Connecticut and around the country. This podcast is brought to you from the UConn Health Interoperability, Innovation, and Learning Lab, where our mission is to promote the optimal adoption and use of eHealth by providing education and engaging in conversation with leaders to create connections for better health. So let's sit back and get connected. Hello, this is Tom Agresta. I'm a family physician and clinical informaticist at the University of Connecticut School of Medicine, and I'll be your host for this episode of Connecticut eHealth Podcast. Today, we're going to be talking about how to improve medication safety with patients, and we have two guests that I have known for several years now, and I consider them colleagues and friends. So today's guests are Sean Jeffrey and Nitya Kashyap, and they previously co-chaired the Medication Reconciliation and Polypharmacy Committee for our state at the Office of Health Strategy. Sean is a board-certified pharmacist. He specializes in geriatric pharmacy, and he's the director of clinical pharmacy services at Integrated Care Partners, and he's a professor of pharmacy practice at the UConn School of Pharmacy. Nitya is board-certified in internal medicine and also board-certified in clinical informatics. She's an assistant professor in internal medicine at the Yale School of Medicine and the associate chief medical information officer at Yale New Haven Health. So it's a pleasure to speak with you today, Nitya and Sean, and I'm going to start off a question for Nitya. So tell us a little bit about yourself and how in the world did you get involved in medication reconciliation and polypharmacy to begin with?
Tom, thank you for having us here. I will tell you that I didn't go into medicine thinking that this is what I was going to do. It's just by virtue of being here. I've been a primary care physician for almost 20 years, and 15 of those have been engaged in some informatics related activity or the other. If you think about what we do day in, day out, an average PCP sees about 20 patients a day, and about 40% of our patients are seeing us for some chronic condition. An average adult in the US may take about 4 to 5 medications. So we are in the business of medication reconciliation, whether that's what we thought we would be doing or not. On the informatics side, it's been a recent development in the past few years, and it started as an activity, sort of almost an interest group with some colleagues and you were part of some of the initial conversations there.
Sean, what about yourself?
I would echo Nitya's comments and thank you for having us here. It's nice to get the band back together, as they say. And so, as you mentioned, my background in pharmacy took me down a path where I focused in geriatrics. And I got some advice from a faculty member when I was training that think about where you're going to be in about 40, when you're in your 40s, mid-career. And then he showed me a demographic of the United States and the population that was going to be experiencing around that same time. And it was largely this tsunami of seniors that would be washing on our shores. And he said, you see all these older folks that are coming your way in your mid-career, they're going to be taking a lot of medications and they're going to need your help. So you better figure out how to deal with meds in older adults. And that's where I began. And if you spend any time working in geriatrics, you know that polypharmacy is one of the key geriatric syndromes that we all face and deal with. So early on, I was struggling trying to figure out, what it is that people were taking, how they were taking their medications, and what we could do to make their med regimens safer. And so much of that initial time was just spent trying to figure out what in the world were they taking. And that whole process of reconciling medications has led me on a nearly 20-year journey to where we are now, as we've seen our electronic medical record systems evolve, as the data is now seemingly at your fingertips, but yet is more disparate perhaps than before. It's become more complicated. And thanks to the state and to folks like yourselves for focusing on this, it's really helped us in Connecticut to, I think, become leaders in helping solve some of the challenges of med rec, WRECK, and turning it into actual reconciliation.
And for the uninitiated, when we talk about actually doing med rec with the REC, what does it really entail, Sean? Can you walk us through a little bit about, in today's world, with the technology that we have, with the people that we have, what does it entail to do it effectively?
So at its very core, it's establishing what is the most accurate medication list that someone is taking in that moment. We know that it's never going to be static, that the meds can change over time, and providers may write or discontinue different prescriptions, and patients may on their own decide to not take things as they're prescribed or just discontinue a medication or maybe even not pick up a medication that was prescribed. So we're trying to piece together all these little different pieces of data to come up with is we call what's the best possible medication history. So what is it that somebody is actually taking that we think has a high degree of confidence of getting into their system? And then from there, you can make clinical decisions that are based in nonfiction, in reality, and you can anticipate what might be side effects because you know that the medication was taken and therefore could cause a side effect, for example. So we spend a lot of time thinking about medication reconciliation and how that impacts different areas of practice. And you can see that it's a challenge as patients start to navigate their way across care settings. So as an example, if you maybe were somebody who's experiencing a stroke and you're taken by ambulance to the hospital, and you come into the emergency room is trying to figure out what medications you took to then decide, is this a stroke that we can treat in one of a couple different pathways? So they need to know critically what are those meds that somebody is taking so they don't increase your bleeding risk, for example. As they transition through the hospital, going from the emergency room to, let's say, an acute stay in the ICU, down to the floor, back, and then to discharge maybe to the skilled nursing facility, meds can change in every one of those settings. So we're trying to reconcile in real time what it is that we're giving and then make sure that the handoff to the next care member has an accurate list of medications. And that's just a challenge because there's so much change that can occur and not all the systems talk to each other. So you get ghost prescriptions, if you will, that exist that you think somebody's taking, but they may not really be.
So Nitu, as a primary care clinician and as somebody who thinks about this from the informatics side, what's your perspective on what Sean has just said?
Sean painted a very helpful picture on what exactly it means medication reconciliation. It's not one thing that happens in one instance. It's a continuum, and it needs to happen at every juncture. I'll share a story from this morning. So what's happened in the last 48 hours is we've had some changes in how we treat patients with COVID. We've had a new drug that's been approved, the first oral medication, and we've had some changes in a medication that's given by intravenous infusion to keep people out of the hospital when they do get sick with COVID. So one of the things we were trying to help with was a pharmacist who looks at the patients who are eligible and tries to prioritize who needs to be scheduled first and who might be eligible for this new medication that's coming out. And we were asking, like, what information can we provide at your fingertips that helps you decide who's sick or who needs to be seen first, and who can be managed with, say, the oral medication. And the first thing that they said, of course, they're a pharmacist, but I think it resonated with the rest of the folks on the call was, just give me the med list. It is such an important thing that tells you so much about what's going on, the condition, the management, the severity, that one piece of information is so critical for the care of someone that you may never have met before, but need to get familiar with very quickly. That kind of brings to the fore why medications and medication lists are so important. And we will be spending the rest of the few minutes hopefully convincing everybody how important the reconciliation of that list is. And it is the season, Tom, so I will take the liberty of saying medication reconciliation is simply the process of making a list, checking it twice, and checking it again. Um,
That's a wonderful analogy.
And if I could just interject there, though, those lists that people make, sometimes those are the most accurate. The little shredded piece of paper that they have in their wallet that they cross out, at least I know that they've taken the time to sit down and try to write something out, and they take it with them with some forethought that maybe it's going to come in helpful in the future. So I put a lot of faith in those lists.
Totally agree. Tom, I know you're going to ask us more difficult questions as we go on, so I'm going to take a moment to say, let's just outline what steps we mean by reconciling, and taking that analogy of making lists a little bit further. It really is 3 steps, 3 basic ones. You make a list, you check it against other sources, and then you make any changes to it. So even though people think that, you're going to see a doctor, or as a clinician, I'm prescribing or removing things, both being important activities, it just simply cannot happen until you have a good base to start with. So that list that's verified, and then make changes.
And that's a wonderful lead into the sort of the next area, and that is that we've been attempting to improve how we do this by involving technology, and yet it's remained quite a challenge in our state and across all of our healthcare organizations. And what do you think that's kind of lacking about even conversing about solutions from your experience, having worked now several years collectively, the two of you, I know because I've been part of it, talking with healthcare organizations, the state, et cetera? What's lacking?
Well, I'll give you my sort of early thoughts, Tom, in that we've had the opportunity working with the state and the Office of Health Strategies, and in talking with lots of different organizations across the country, reviewing published literature, and in just talking to clinicians, prescribers, pharmacists, and e-prescribing hubs. What's striking is that people start with the process of, here's a medication, let's go manage from there on. There's very little conversation, to our understanding, that talks about compiling that list in an automated manner. It presumes it's people that are doing it. And it may just be a reflection of the fact that we are just at a very good juncture where there are lots of enabling technologies available today that we didn't have a few years ago. But that's where the conversation is. Relying on individuals to try and make phone calls in the middle of an emergency room visit, or as an EMT, trying to figure out and relay that information to an emergency room physician saying, this is the medication someone takes. And you may not have all that complete picture, a complete and accurate picture that is automatically available and shared across multiple people. I think that's the part that we're striving to do. And it's been missing in the conversation, partly because it just simply didn't seem possible to do.
And I'd add to that there's historical reasons why this is challenging, and that there's a lot of different factors, and I'm not trying to make excuses, but think of how different practice settings have evolved over time. And I'll use the example of pharmacy as one where, as a profession, pharmacy, especially in the community setting, was one of the first to adopt computers. It was the first area to really have any sort of record keeping that was computerized. And they needed to because of the volume of the prescriptions, and it was more transactional, right? And you had to adjudicate a claim, and you had to then be able to pay out for the prescription and have your records that all matched. But all of that environment that was very sophisticated and was created over decades was outside of what was created within electronic medical records. So they're very different systems that we're operating. And even to this day, we don't talk very well across that space. So bringing the community pharmacy world into what's happening within electronic prescribing in an EMR, sure, we can e-prescribe very easily, but to have meaningful bidirectional conversation around the management of those prescriptions is hard. It's not something that fits easily into workflow, and may actually create more barriers. And we're working on some issues right now around the number of in-basket messages that providers get. It's just overwhelming, the amount of information that can flow, but is it really the right information that you need at the time you need to make the decision, right? And that's the big challenge, I think, with med reconciliation.
It's something that I know has been partially unearthed and talked about as part of that MRPC, or the Medication Reconciliation Polypharmacy Committee. And as the MRPC finished up its work, can you walk through a little bit of the things that were discovered? That in the second part of our podcast, we'll talk a little bit about some of the solutions that you are all working on. Things like, what is a BPMH? What about some of the functional requirements that actually are in needed? And what about user interface requirements? What is it going to take that was uncovered as part of that MRPC?
So I'll start by saying the MRPC's work spanned over a year and a half, maybe 2 years. So for us to fit that all into the confines of this podcast might be a bit much. But at a high level, it created the space for a conversation to occur about what's meaningful in reconciling meds. It helped us to drive towards consensus around terminology, to understand the different practice settings and what their requirements are. So thinking, early on, some of the things that came out were the needs of a home care nurse are going to be very different than perhaps a med reconciliation technician in an emergency room. But yet they still have similar data elements that they're going to be drawing upon. So through the process of this committee and the work that we did and the external subject matter experts that we were able to draw on, we outline what would be the business requirements and the functional requirements to make med reconciliation practical. The next step of that, obviously, is what are the technical requirements and ultimately who's going to pay for this and how does it get scaled. But along that journey, we identified things that you have to consider in terms of when you do create a list, how's that list going to look? What's the user interface need to be? What are the privacy controls that you need around that? Who can access it? What level of access? Is there the ability to go backwards in that list, for example, to see changes that have occurred historically? We talk about a ledger type concept where you could see where somebody discontinued a medication and maybe what was that reason for that discontinuation. That's elusive for a lot of EMRs to be able to have that type of longitudinal tail to somebody's medication regimen. So we spent a lot of time as a group chewing over the various aspects of a med regimen, ultimately landing on a best possible med history as the terminology that the literature was supporting and what we recommended moving forward, and made those recommendations to the Office of Health Strategy, which have then helped to inform the newly launched Health Information Exchange in Connecticut, Connie, in a work group that's taken the essence of what MRPC has and is now driving towards I think a concrete solution.
Well said, Sean. I will just say the efforts in the last 2 years have allowed us to have a good conversation about the med list in the context of yours, mine, and ours. We had stakeholders from across the continuum, including patient representatives, nursing, home healthcare nurse, pharmacists, external vendors who support some of that infrastructure that John was just describing. And what we allowed ourselves to do is describe the issue of medication and medication lists from each of our perspectives, and realized that even while we were talking about the same thing, we looked upon that same thing as coming from different sources in a different shape or form, almost like looking at different parts of the elephant. And in doing so, we were able to find common areas, and that's the recommendations and the distillation of what came out of this in terms of requirements. Certainly a lot of work ahead to build upon those things. And Tom, you alluded to sort of the objectives that the MRPC had, and Of course, this is all public information available for anyone to look at. We had 5 objectives, but really what we were able to achieve was broader than that. And the biggest thing that came out of it was a safe space for a broad coalition of members who are actually still contributing in one way or another in multiple different avenues. The other thing that came out of this work was early on the concept of medication cancellations. One medication gets discontinued, how is it communicated across entities? And believe it or not, that technology existed for about a decade, but just was a well-hidden secret. And with the efforts of everyone involved, we were able to get that to the surface and increase adoption. We went from sort of way behind in the race there across the country, and we now lead in adoption of that piece of technology. Well, why is that important? Well, if you keep things that should have fallen off that list is never going to be accurate. It's a critical piece of getting to that best medication history part. And of course, as John was pointing out, the distillation of the work in terms of the requirements will continue to inform future work. We hope within the state, but also probably across other domains as well.
Yeah, I agree.
And just to add to that real fast, though, because in Nitu, you made a good point about how it created a safe space for the conversation to occur. Anybody who's listening to this podcast is probably aware that there's a lot of work being done out here, and a lot of it is by individual vendors that have a proprietary interest in a particular aspect of a solution. And what we try to do is think much more broadly about what does a solution look like for the citizens of Connecticut, for the health systems, the providers in Connecticut. So it was a more holistic approach than maybe what you might find in different commercially available solutions.
I agree. Some of the work that has been done over the last several years has dramatically, I think, improved patient safety, especially the improvement of usage of Cancel RX, which is that cancellation technology that Nitu mentioned. So kind of thinking forward, we're going to take a break. And then after that break, we're going to talk a little bit about what's going on now and into the future. We want to take this opportunity to thank Connie, Connecticut's official health information exchange. Connie was established in 2019 to oversee and provide services to support the exchange of health data in the state of Connecticut. Connie is an independent and not-for-profit organization. To learn more about Connie, please visit conniect.org or go to the show notes from today's episode. And now as we return, we were talking in the past about the MRPC that has now ended, and you're now moving into a phase where you're trying to figure out how to implement some of these suggestions in a real space, utilizing the Health Information Exchange, Connie, as our state's designated health information exchange. What can you tell us about your work with Connie, and how does it tie into the previous work, and where is it going?
I'll kick us off on that one, Tom, and Sean will keep me honest. He could probably read my mind at this stage, having worked with us in so many years together. With the state HIE, or Connie as we call it, we're involved with one of the work groups that relates to best possible medication history, and we're happy to share details during the rest of the conversation. What we hope to do there is to take the work that was done previously in the space of medication reconciliation and defining what this single best timely medication history would look like, and what it should at basic minimum have in terms of requirements, and who can access it, and at what point in time, how do you have some safeguards to it. That's kind of the work going forward. And importantly, to add the layer of time and resources on top of it to see what's feasible, viable with the available resources and what time frame. So that's the work we're doing going forward. But to tie into why sort of we went from a committee to the HIE for your listeners, it's helpful to understand, I guess at a very basic level, when you're trying to develop this best list, we've mentioned that you need some source of this medication, and it's usually a few different places, perhaps the doctors, EHRs, perhaps the pharmacy. So a few different sources. There's an output on how people will interact with it. In the middle sits a processing engine that kind of takes all these multiple sources and sort of mixes it all up and turns it into something more wonderful than the input sources. So there's three parts to doing that. And if you think about it, the state HIE already has done a lot of thinking on what the sources would be. It is providing a framework for this processing engine to sit on. Of course, it will not be a Ferrari to start with. It'll probably be a scooter, but that's okay. We'll get there. And then we've defined with the MRPC what the output should look like. And in order for the output to look like what we want it to be, what the inputs should be. So it all seems like it was just a natural continuation of the work that was done. And we are poised to take advantage of that work in this time and space that we have.
Sean, would you like to add a little bit to that?
The MRPC and the work that that group contributed really was foundational for what Connie is now building on. And if you can imagine, we did a lot of the survey and background work within MRPC. What we're doing now within Connie is getting more granular into the technical aspects of actually connecting the pipes and seeing what that will look like and who's going to be able to access, and ultimately what will the end user be able to see and how does that look and feel to them. So we identified a lot of those components within the MRPC. This is where, to use a phrase, the rubber hits the road, and we're getting much more specific about what is feasible. And I think that's the word that we've tried to focus the committee on is, yes, there's lots of things that could be possible, but what is feasible in the near term so that we can make this a reality.
And I love that idea of, actually getting something built, tested out there, and then improved on, because I think there is an opportunity for it to grow and improve over time. You both mentioned sort of the pipeline data coming in, and I know that there's just the sources of data, but then there also is the structure and the reliability and validity of that data. Would you like to share a little bit about what you're learning from the HIE perspective and how you're focusing on some of those areas?
This may be where there's going to be some strategic edits made, but
okay.
I'll be honest with you that the data at this point is, it's still unclear to me what the ultimate reliability is going to be until we see everything flesh out. I mean, that's my sense of it. I don't know if you feel differently, Nitu.
Yeah, I'd agree there, Sean. I think we all think that our product is perfect unless it goes out into the real world, and then you realize, oops, we didn't realize this is how we were recording something. And then you go back and improve on it. So since it is going to be multiple people contributing at the same time, what we have to watch out for, it's kind of like going to be too many cooks in the kitchen, or will it turn out to be sort of a different analogy of working together and making something bigger and better? It probably is going to be a combination of both, but there is I guess a cautiously optimistic viewpoint that we all have, that yes, there will be some gotchas that we'll find, and there will be an opportunity to improve on it. But at every step, what we come up with will be better than what exists today, which is exactly nothing. The other thing that actually Connie has offered us, and the HIE framework across the country has, if you think about it, Connie has a legislative mandate that's behind it that requires that all hospitals contribute clinical data by May of 22, and all practices and skilled nursing facilities do the same by May of 2023. And that mandate gives us clinical data that includes medications, without which I don't think there was any incentive for people to contribute to it, right? So that facilitates that multiple source contribution, which we would not have been able to otherwise get ahead of. The other thing that sort of you see that are the checks and balances in terms of who can access this information from where, at what point, how do individuals opt out of this space. All of those privacy and security conversations are so critical, and they're happening under the big umbrella of the HIE. So we don't have to individually tackle them in the context of medications. So there's a lot of sort of positive stuff, but there's cautious optimism to proceed in this direction.
And I guess the other thing that we're going to be exploring and trying to figure out is, as the data starts to flow and people start to interact with it, what's the most meaningful way that it gets displayed? And then how do we provide confidence in the information? And the example might be that, we have prescription data for a chronic maintenance medication that somebody's been receiving for years. And you can see that their refills are generally on time, so the calculation of medication adherence is very high, which gives you a high degree of confidence that somebody might be actually taking that medication. Is there a way that we can graphically represent that to the end user so that regardless of the source of that information, you have a high degree of confidence that this is something that the person's actually taking? And conversely, maybe there's meds that are showing up that you have a lower degree of confidence that they are receiving because you don't have the other data points that suggest the person's actually getting it filled or taking it. So those are things that we're going to be kicking around to try to see what that will look like to the end user.
Yeah, I certainly see that in my own clinical care, where sometimes I'm caring for a patient in my primary care setting, and they see several other specialists that are in other healthcare settings. And, there is some electronic exchange of information between those settings, but often you'll see different medication lists across those different environments. And if I can see that the patient has, picked this medicine up at the pharmacy, I'm much more likely to believe that they're taking it. And I think if that's capable of really occurring at the level of the health information exchange, that would be a wonderful benefit, especially for those that don't have any connection to the electronic exchange of that data. If you were to look ahead a little bit, knowing what's mandated from the state with regards to data coming in, knowing also that the state is requiring that patients get access to their health information exchange, what would be the best sort of outcomes in, let's say, 5 years? We're talking out now, 3 to 5 years out, not the immediate stuff. I hear the immediate opportunities and challenges there, but what would you see down the road?
So I'm hoping that what we have is a solution that is actually something that is useful, first and foremost, that is able to be used within a workflow that doesn't become cumbersome where you have to go out to a separate location just to try to query this information, that it's feeding at a point of care where the decisions can be made in a timely manner. And then I would also say that maybe that future state involves something that I know this group has talked about and our patient advocates have clamored for, and that would be the ability for the patient or proxy or caregiver or whoever's helping to manage, we define who that person is, the medications, the ability to comment back to the prescriber if a change needs to be made on a med. And maybe that there's been an alteration in how somebody was taking a prescription, or they weren't able to get it, or they don't want to take it because of a side effect. so that we really get to a point where it's very patient focused, patient centered, and there's a sense of ownership by the individual that they are helping to curate their own list and making it as accurate as possible.
John, that's very well said. I will echo those sentiments and say that in 5 years, we hope to have a single hymn book that everyone is singing from. And if there is a note to be changed in one part of it, that is reflected in all of our copies. And that's the ownership is then not, oh, my doctor has the list, but I know what it is. And I'm able to share it with the individuals I deem important or to my care, whether it be a family member or another clinician when the need arises. And in case of an emergency, when I'm not able to share that with the EMTs or the emergency room physicians, they have a place to see my list in the way I would have wanted them to see it. So it's kind of that vision that we're keeping as our true north. And it seems very much reachable, but not without effort that is happening today.
I'm glad we only have to be singing from the same hymn book and not all in tune.
Well, that gets to the difference between interoperability and semantic interoperability, which is one of the techie things that we do cover sometimes in our eHealth podcasts, which of course is an important thing, and it may be the 5 to 7 year time frame that we look at for that. I think the work that's been going on in the past and the actual work at the health information exchange level that you're doing at Connie is pretty unique, and it puts Connecticut in a unique place. Would you like to comment on that and share how that is both an opportunity and a challenge for us?
So this is like when you are trying to go on a hike and you have to make your own trail. It's not easy the first time you do it, but the next person who comes along will have an easier task of navigating that same place. We had an opportunity to talk to a lot of individuals across the country, including HIEs, and they're struggling with sort of making that list, gathering all the sources, and that's been their focus. We have arrived at a time when I think Connecticut has a latecomer advantage. We can learn from those things and not make the mistakes that they made and build upon it. So if we're able to do something in the space of medication reconciliation, to our knowledge, it hasn't been done in another space before, whether it's the HIE or another mechanism outside of probably vendor products with their limited scope. So we are poised to do something that can benefit more than just the citizens of Connecticut. And we certainly have the right milieu of public and private partnerships here.
Well said, Nitu.
So in kind of setting up our closing for this conversation, what would you like to share with citizens of Connecticut, with the healthcare organizations, with pharmacy organizations about how they can facilitate or help or participate in some fashion with improving the way we do reconcile medications electronically? What would you like folks to know, and what would you like them to do?
As I was thinking about this question, the thing that comes to my mind is that over the course of my career, the amount of change that we've seen occur. I started practicing in the VA system, which had an electronic medical record system back into like 1995, but it didn't talk to anybody other than other VA systems. So you could look at meds for somebody in Connecticut who went to Florida during the winter and got their meds filled at a VA down there, and then came back in the summer to Connecticut. And we thought that was really cool, that we could see that kind of transaction across states and follow somebody longitudinally. But then they go to CVS and we had no idea what they picked up at CVS. And what we've now, I think, witnessed is there's much more transparency and sharing of that information across platforms to the point that it's really becoming very useful and timely when it's needed the most. It's not perfect, and we understand that, and that's why we're doing all this work to try to make it the best possible scenario, but it's gotten so much better. So I don't want people to lose sight of the fact that progress, real meaningful progress, has occurred over the last 20 years for sure. Now, there's ways that you can still get involved in that, and that's to make sure that within your own health systems, if you practice in one, that your informaticists are plugging in and participating in these work groups and are helping to contribute their time and effort and talent to thinking about how they're going to roll out things like Cancel RX, or how they can help to improve the education and training around med reconciliation and best possible med history. And that we're all using, to Nitu's analogy earlier, we're all singing from the same hymnal here. So I would say getting involved is key. We both of us step forward. I wouldn't consider myself an expert in this area by any stretch of the imagination, but I had a clinical passion for trying to make it better. And you don't have to have that expertise, but do step forward and give us recommendations, give us ideas on what you're seeing or observations on what could be improved, because unless we know what your pain points are, we can't build ways to help that get better.
Sean, I completely agree. Here's a plea to everyone: if you see something, say something. And it goes for your individual experiences are very, very valuable, because we can get caught up in the weeds, but you can bring us back to reality in terms of all of that can be solved with interoperability. And Tom used some big words of semantic interoperability. Still ways to go, but how do we actually make sure that anything that we're doing has impact on the front lines? We really need to see people engaged. The one thing I always find is when we talk about technology, people always, either they're informaticists, Tom, like you, who will be like, sure, bring it on. Or for the rest of us, it's mostly like, it's a mess out there. But think of it as that picture can be messy, but it's important for us to keep our eye on it. It's no different than how when your children make a mess in the kitchen, you still have to go out and talk to them and figure it all out. And that's kind of solve it piece by piece, pay attention, stay involved, stay engaged. There is enough data to say that medications save lives, and medication safety, if not understood, can cause harm. And that's what we are trying to avoid.
And one more point that I learned in co-chairing the MRPC with Nitu is that so much of this work that we were involved with was public. And the public has the opportunity to chime in. So you can find out when these meetings are occurring. Attend, listen in. Almost all of them have a public comment period. So if there's something that you want to say, don't be afraid to come forward and say, I'm seeing this as a concern and I think people should focus on it, or at least have it on their radar screen.
Yeah, Tom, if I may make a plug for the repository that we have for all the resources that were compiled during the MedRec process. And that's also available. Hopefully you can share with the listeners how to access this.
Sure, we certainly will kind of put links to those pieces of the reports that were generated, the committees that have met. We'll have that all available as part of our show notes. I'd really like to take time to thank you. I consider you to be excellent colleagues, collaborators, and leading a really important thing in our state. And I think that it'll spill over to other states. I know there's places that are on our borders that want to collaborate with us already. And I really appreciate the time and input that you've had today. And although this will be broadcast after this season, we are recording this right before the holiday season. So I do want to wish you both a wonderful, healthy, happy, safe holiday. And thank you very much for your time and effort.
Thank you, Tom, for having us, and happy holidays to everyone listening and to you as well. Be safe, be well. Catch you in the new year.
That's right. Make your list and check it twice.
As always, wishing you the best of health. Your host, Tom Agresta.